welcome to Listen Up, People, a podcast of the USC Dworak-Peck School of Social Work. I'm Dr. Holly Priebe-Sotelo, Associate Teaching Professor of Practicum Education and your host for the second season of the podcast. In today's episode, we're exploring aging with HIV and AIDS. An HIV diagnosis was once considered a death sentence, but with modern treatment, that has changed. People living with HIV and AIDS today are becoming first generations to age with this disease and pioneer a new path for what that means. My guests today both focus much of their work on aging with HIV AIDS and how our systems can best support them. Dr. Sara Schwartz, Associate Teaching Professor and my colleague at the USC School of Social Work, is an expert in the area of aging with bleeding disorders, HIV AIDS, historical trauma in diverse communities, and visual social work. Sara serves on the board of directors of the National AIDS Memorial and is a co-producer of the annual Surviving Voices documentary films. Her colleague, Dr. Paul Nash, is an instructional professor of gerontology at the USC Leonard Davis School of Gerontology, whose research focuses on ageism, discrimination, and prejudice, with a particular focus on aging with HIV and AIDS. Sara and Paul have collaborated extensively in the field, and I am pleased to welcome them here today to discuss this important topic. Great to have you both here today. I'd like to start off our discussion by asking a more personal question about how you became interested in this work. So let's start with you, Sara. How did you become involved in advocacy for people living with HIV and AIDS?
Thank you for having me, Holly. I grew up in the Washington, D.C. area and was a latchkey kid in the 80s and watched all of this unfold on my television set, the AIDS crisis, and was very aware of the social action organizing going on with ACT UP and then the AIDS quilt when it came to Washington, D.C. in 1987, and began volunteering with this community. When I graduated from college and moved back to the DC area, I think it was 1995, I began volunteering at the food bank for people living with HIV/AIDS, receiving services from the Whitman Walker Clinic, and have been actively engaged as a volunteer ever since. My research pivoted about 8 or 9 years ago towards this area.
Excellent. Thank you so much. I didn't know that about you. Paul, and for you?
So I started off as a psychologist and I was interested in prejudice, and that quickly pivoted towards ageism as an area that was largely underrepresented and under-researched. And once working in that field, I became exposed to different researchers around intersectionality and some of the work by Stephen Karpiak, who is recently deceased, but he introduced me to the work around aging with HIV and asked me to look at ageism in the world of HIV. And as we started to explore that area, we found an underserved and an under-researched community that was far more diverse than any of the existing knowledge bases was really reflecting. So my area of research has really blossomed over the last 5 years or so within that area. And as with Sara, my advocacy has followed with that, becoming a commissioner for the Los Angeles County Commission on HIV and leading the HIV interest groups for national organizations like the Gerontological Society of America.
Excellent. Oh my gosh, that's great news to hear. And then we can all agree then, and I'll pose this question to Sara, that aging can be challenging to navigate, obviously, under the best of circumstances. Can you talk a bit about how that is complicated if someone has a bleeding disorder and they also have HIV or AIDS?
First, I think it makes sense to share how I became involved with the bleeding disorder community in the first place, as I'm not a member of that community, but I currently sit on the board of directors of the National AIDS Memorial. But prior to that, the HIV Story Project built a partnership with the National AIDS Memorial to begin making short films each year called the Surviving Voices Project that document the stories and histories of communities who were impacted by HIV and AIDS, whose stories have not often been told. Our second in that series was on AIDS in the hemophilia community. And that's how I actually first learned about the history of the contaminated blood supply and how that impacted people who were using the national blood supply for treatment for their bleeding disorders, including hemophilia. Of course, I knew about Ryan White, but I was really shocked that I didn't know this history prior to that, and began a pro bono research project to collect the voices of this community and how the contaminated blood supply impacted it. So I've built a data set of over 80 interviews over the past 7 or 8 years from multiple perspectives, from mothers who lost children to HIV and AIDS from the contaminated blood supply or siblings. But about 6 years ago, I started a project looking at people who are aging, who survived the contaminated blood supply and are now aging with a bleeding disorder as the first cohort to actually age with a bleeding disorder. For many of them, that includes an HIV diagnosis. And for most of them, that includes a diagnosis of hepatitis that they most of them cleared in the 1990s with treatment. So it's very complicated. Aging is complicated anyway, but when you've been on the the retroviral medications for 30 years, plus you have joint pain, arthritis, injuries from your bleeding disorder, it really complicates the process. And emotionally, there's a lot of trauma in this community. There's trauma in the bleeding disorder community, trauma from physical pain, emotional pain, being othered, stigmatized, socially isolated. And then there's the trauma from also having a diagnosis of HIV and AIDS, which was also stigmatized and not ever expecting to live this long. So this is a population who never really anticipated growing into older age. And for many of them, they did not prepare themselves for it and are trying to navigate a health system and a medical system and a social system that is also not prepared to help them age.
Thank you for your work. And Paul, would you care to answer to that question as well about the complications of the bleeding disorders?
With regards to bleeding or disorders specifically, I am definitely going to defer to Sarah's expertise in that. But the only thing I will say is a bit of a counter. Yes, there are challenges that we associate with aging, but it is a huge age of opportunity as well. And we often undersell the contributions of older adults, but the contributions they make both economically, socially, and through community cohesion is phenomenal. So we should think of it as a time of opportunity rather than just as a time of challenge.
Excellent. And Paul, which leads me to my next question really is that we know that your area of research expertise is marginalized communities, such as those aging with HIV/AIDS that also face additional challenges due to sexual orientation, race, gender, or socioeconomic status. How do you explain a little bit more about the intersectionalities and how they're impacted with the experience of aging?
Yeah, no problem at all. Especially in this day and age, intersectionality is a word that many shy away from, but it really matters when it comes to people aging with HIV and AIDS because HIV doesn't exist in a vacuum. It's layered onto other identities and life circumstances that help us shape access to care and overall well-being. So when we consider HIV stigma and other stigmas like homophobia, racism, sexism, ageism, classism, etc., they stack rather than simply add. Therefore, older adults with HIV might face discrimination in healthcare, housing, long-term care facilities, and social services, which makes them reluctant often to seek help. So for LGBTQ plus individuals specifically, aging can mean returning to environments like nursing homes where they feel pressure to recloset themselves for safety reasons. And these challenges can lead to increased isolation, delayed care access, stress, and poor mental health. Linked to this, health disparities are also a concern because people who are aging with HIV already have higher risks of things like cardiovascular disease, cognitive decline, frailty, and multimorbidities. These risks are often worse for racial and ethnic minorities because of long-standing inequalities with regards to healthcare access, healthcare quality, and treatment bias, which result in earlier onset of age-related conditions and more complex health management. And we talked a little bit about economic security, and that's a problem for older people who are living with HIV, especially women and people of color, as well as those as part of the LGBTQ plus population, because they're more likely to have experienced interrupted careers, employment discrimination, and lower lifetime earnings, which result in lower savings, unstable housing, and reliance on underfunded safety net programs. burdens. And all of this means that they have difficulty affording medications, food and transportation, which causes more troubles as they age through the end part of their years. And linked to this, women with HIV, for example, they often face unique challenges like later diagnosis, or they're more likely to have caregiver burden. And they're also massively underrepresented when it comes to HIV research. And specifically, when we look at transgender communities, these individuals may encounter barriers to gender-affirming care, which is compounded by then HIV-related stigma. So gender-related stigma results in these gaps in appropriate, culturally competent healthcare, as well as putting up higher mental health burdens. One of the big ones that we don't talk about is social isolation, because that can cause huge problems where many long-term survivors may have lost partners, friends, and community during the earlier waves of the epidemic, and they might face family rejection, which is also more common for LGBT people, as they may have fewer traditional caregiving networks, which increases the risk of loneliness, depression, and also a greater risk of cognitive decline. But despite those challenges, what we see is many older adults with HIV demonstrate stronger coping skills, activism in the community, and they have deep health literacy. So to answer your question, in sum, intersectional identities really shape HIV by amplifying the inequalities across health, social, and economic domains, but they also shape resilience and they increase community bonds. So addressing these realities requires integrated, culturally responsive, and anti-discriminatory practices across healthcare, services, and social policy.
This is really eye-opening for me as a professor that is trying to work with young students and helping them to really examine all the complexity behind working with clients, that it's never just one matter. It's never as simple as this one solution. So thank you so much. Would you care to add anything, Sara?
Well, I was thinking that it might be interesting, since this is a social work oriented podcast, to talk about the amazing activism that happened in the 80s and 90s in the communities impacted by HIV and AIDS. My short film, Gert's Boys, that's free to the public now. Just Google Gert's Boys, which is about one of the founders of the AIDS quilt. I do try to weave stories about the social action organizing that happened in the 80s and 90s, ACT UP, the quilt, Shanti, support groups, community supports, food kitchens to care for each other, right? The community that was impacted built these supports to advocate for the government to provide funds to discover treatment for AIDS, but also to come together and support each other. As Paul had mentioned, many people were abandoned by family members and had lost friends. That's an important time for social workers to understand historically. I do think we need to understand our past to understand our present and have a pathway towards the future. Yeah, so I wanted to include that. I also wanted to share that I'm working on a second film right now, which is on one of these support groups that has existed for 39 years. It's called the Mothers of Bleeders Support Groups. And this was a group of women whose children or partners or siblings were infected with HIV from the contaminated blood supply. And they built a support group that continues to meet every few months for 40 years. And they are aging together and losing members of the group, which is interesting to experience alongside them.
Wow, thank you so much. Again, so informative. Paul, I'd like to ask for your perspective. I know that the HIV was technically the first pandemic in our modern scientific era. And I know that you and Sara have presented research around how the COVID pandemic impacted those still living with the legacy of HIV pandemic. Can you share some of your research findings about this topic?
Yeah, I think COVID was a real eye-opener for many, but it often unlocked a lot of packed away trauma for many of those people that had been through that initial HIV pandemic. So many people with HIV experienced interruptions to their routine care during the pandemic. When we experienced lockdowns, clinic closures, and shifted healthcare system priorities meant that there was disruption in antiretroviral therapy access, viral load monitoring, and HIV prevention services. So in some regions of the US, HIV testing and prevention programs were scaled back or paused, which slowed the progress towards early diagnosis and treatment goals. And in response, many programs implemented multi-medication dispensing or home delivery or telehealth to try and maintain some community continuity of care. Multiple studies during that pandemic have studied and worked with people who are living with HIV, and they've noted many mental health impacts. So, for example, I talked about stress and isolation before, where people experience these pandemic stresses, including fears around co-infection, social distancing, and service disruptions. This exacerbated anxiety, disruption, and psychological distress for people who are living with HIV. And that linked to a reduction in mental health care utilization. And when we look at large-scale data in the US, it shows that mental health care visits decreased amongst people who are living with HIV during the pandemic, even as their needs were growing. And disparities were again larger by race and insurance status. And many people living with HIV already carried those histories of trauma, stigma, and loss. And the pandemic's isolation is likely to have re-triggered memories and stress linked to the early HIV years, compounding those mental health challenges. Interestingly, the dual pandemics also magnified existing disparities. So people who were living with HIV, who were also part of marginalized groups like racial and ethnic minorities, often experienced greater service disruption, greater mental health stress, and lower healthcare utilization. And these structural inequalities shape not only HIV outcomes, but also the vulnerability to COVID-19 exposure, as well as severe illness, which again echoed the patterns that we'd seen in the earlier HIV pandemic. So when we come to sum all this up, when you look at our research, the COVID pandemic impacted people who are living with HIV in multiple ways. It disrupted their healthcare systems, which revealed both vulnerabilities as well as innovations when it comes to service delivery. It exacerbated mental health challenges, especially where social support and care access were limited. But it also highlighted and deepened health inequalities, particularly for those marginalized communities we talked about. And it reinforced public health lessons that we learned from that HIV pandemic about the importance of community-led approaches, equity-focused responses, and also resilient healthcare systems.
So where are we now versus where we were with HIV/AIDS, and where are we going under the current federal healthcare changes? I don't know, Sarah, if you'd like to answer that, and maybe Paul.
I think Paul is more versed in the statistics, but I will say I'm very frightened about what is happening politically right now. You know, in order for someone's HIV diagnosis not to become an AIDS diagnosis, they have to have the medication to treat it. And in order to have the medication to treat it, they have to have health insurance and access to the medication. So I'm very concerned about what this is going to look like in the coming years. But Paul, I think you have more information on projections of that.
Yeah, to say it's a scary time is a little bit of an understatement, to be honest with you. We're looking at reductions in HIV funding. That's not just research in service delivery as well as service prevention. As part of the Los Angeles County Commission on HIV, we're responsible for allocations of those funds, and we're really struggling to meet the needs. We know that, for example, the Department of Health has cut the budgets for service delivery and as well as any of these interventions that help keep people well. As Sarah said, what's really important is trying to not just get people into care, but keep them in care. It's that continuum of care that we're really, really interested in, and that can be linked to people's insurance. It can also be linked to people's willingness to engage with services, the targeting of certain groups by immigration services, for example, regardless of immigration or migration or citizenship status. People are afraid to go and collect what they need. They're afraid to go to screenings. They're afraid to go to support groups. So we know people are dropping off. When we see Medicare, Medicaid cuts, when we see the reduction in Affordable Care Act subsidies, we know that is going to impact people who rely on those medications. And yeah, we're starting to look now, not at ending the HIV epidemic, but modeling how many people are going to die from HIV/AIDS. That just wasn't in the narrative even 12, 24 months ago.
Well, this is such important information, and I do encourage our listeners to continue to learn about the topics, get involved. I know sometimes people are feeling very discouraged at this time, but this is not a time to be paralyzed in our fear. We need to continue to educate ourselves and what we can do to get involved. So as we begin to wrap up our discussion here today, is there anything else that we haven't quite talked about that maybe our listeners would like to know about this topic of aging with HIV and AIDS? I'll start with Sara and then Paul, please.
I do believe that we are living in a historical time where history is being rewritten and erased, and our younger generations really don't know their history very well. So I encourage our audience to travel back in time, learn about HIV and AIDS in our country and internationally, learn about how our government responded to or did not respond to the crisis, and learn from those lessons and have hope. This was an amazingly powerful movement. There are long-term survivors. We can learn from them. And you're right, we have to have hope as we look forward.
Excellent. Thank you, Sara. Paul, any final thoughts?
Yeah, I really want to echo what Sara said. Is we've talked about intersectionality, and each one of these communities is massively resilient. This is not the first time, and it is unlikely to be the last time that they are targeted by people in power. These communities do not fall. These communities stand together. They build in strength. What we need to make sure as people are coming from a position of privilege is that we look towards inclusivity. We look towards representation, but it's not tokenistic. We need to have meaningful engagement. It's not just about having people's voices around a table. It's about putting people with those voices in positions of power to make real change. We need to meet people where they're at, but we also need to make sure that we've got the resources to enable people to get ahead of the growing need that we're facing. We're heading rapidly towards 70% of the people who are living with HIV being older adults. That is a success story, but we still have much we don't know about aging with HIV, whether that is long-term survivors or people who are acquiring HIV in later life. We need to get our heads around the fact that people over the age of 60 have sex. We need to talk about sexual health at all ages, and we need to remove this stigma of ageism when it comes to engaging people in healthcare and make it less about dollars and make it more about person-centered, meaningful care.
Love that. I mean, I'm taking notes here and thinking about, there's much to be celebrated in the work that you've done and that has taken place so far, but there's still much more to go. Yes, please, Paul.
Yeah, the only thing I was going to say is I'm going to hold Sara up as a poster child here is there is huge amounts that gerontology and social work can do together. And Sara and I, we show this. And I work with several colleagues in the School of Social Work, and we are a powerhouse together. Very rarely do we actually work together. USC is a powerhouse of silos, but we are, again, like these communities, these intersectional communities, we are stronger together. And I would really encourage people who are listening to this, if they're social workers, go and bug the School of Gerontology, go and speak to people that work in aging services. And similarly, people that work with older adults, get that social work perspective. These are unique but really complementary approaches.
Yes, beautifully said. We are stronger together as a society. We must continue to educate ourselves, to work collaboratively with our partners within the university and outside. And really, again, this is no time to give up, right? To maintain that hope. So incredible, incredible. I wish we had more time. I'd like to thank you, Sara and Paul, for joining us for this very important and critical discussion. If you would like more information about the USC School of Social Work, please visit Dworak-Peck.usc.edu. And if you're interested in learning more about aging and gerontology, please visit gero.usc.edu. And if you'd like to network with our guests regarding their work or want to support our transformative research and programs, please email us at Listen.Up.People@usc.edu. Thank you.